Hi, it's Tom here from Running Physio. Today I wanted to start a new series of videos with you about getting unstuck. Now, we all, I think, get stuck at times in clinic treating athletes. Caring for people is complex. They often have quite complicated needs, and it can feel like there's quite a lot of weight on our shoulders when we want to look after someone, when we want to help them, when we know that actually their sport is really, really important to them, and we really want to get them back to that. So I wanted to start this series and look at common areas where we all tend to get a little stuck. And I think there are often points where we will all find these certain things challenging, and to explore these areas a little bit with you to help you find solutions. As ever with these videos, they are for you. So please let me know in the comments, where do you feel stuck when you're treating athletes? What issues do you find difficult to resolve with them? Are there particular injuries you're treating at the moment, perhaps, that you'd like to know a little bit more about and you feel that you could get a bit of guidance from us on? Or maybe just particular parts of the assessment or treatment process that we can help with? So please let me know in the comments, because your answers are going to inspire the next videos in this series. Now, today's video, we're going to talk a little bit about one area where we commonly get stuck, which is when we're not really quite sure what's wrong. Perhaps we're struggling to recreate someone's symptoms, we're not clear what the diagnosis is, so as a result, it's difficult for us to proceed forward with that person's care. Now, quite often we reach out for help with this, and actually partly what's inspired me to do these videos is looking at some of the responses we see on various groups and things when people do reach out for help. We'll often say, I'm seeing this patient and we're not really getting progress, and we'll describe the symptoms, and then we'll get a great big long list of answers. Now, this is good because people are trying to help, but actually quite often it's confusing, because those answers are picking at little details which probably in truth aren't going to be the big difference. So whether this person has a slight leg length discrepancy or slightly anteriorly tilted pelvis, or whether they need to be doing a little bit more core work, all these suggestions that come through, they're well-meaning, but quite often they're not really going to quite do the job. So we want to think about what are the actual helpful things here, what are actually going to make a difference for you in clinic, rather than giving you a great big long to-do list of stuff you need to test and work through with the patient. So let's start with this first issue of not being sure what's wrong. And one aspect of this sometimes we can have with athletes in clinic is that we can't recreate their symptoms. Now, this happens quite often with runners that might only be getting pain at a certain point during their run, and they come into clinic, and when we test them, we don't really find anything. And as a result, then it's quite difficult for us to confirm a diagnosis and treatment plan. So if you're struggling with that with a runner, a simple thing that you can do is get them into clinic, get them running within clinic, perhaps on a treadmill if you've got it, or in the local area if you haven't got a treadmill. Get them running to the point where their symptoms are coming on. And then you can run your tests with their symptoms present. So you can look at all the key tests of range, of strength, of diagnostic tests, etc., when they actually have pain, and it's much easier for you to reach a diagnosis. But also what's very useful about this approach is you could be doing their gait analysis during this process. So you could be videoing their gait to see, are they running in a way that might be putting more stress on this painful area. And you can also use this test to see what their running tolerance is, because you can measure how long in time or how far in distance does it take before your symptoms kick in. And that's really useful, because you could use that to put together a return to running program for them. So simple stuff, but actually practically you can get an awful lot out of that approach. So if someone's symptoms aren't really coming on with your testing clinic, get them running, look at their gait, see at what point the symptoms come in, and then you can test them and see what the diagnosis is likely to be, because you'll have symptoms there which will guide your answers. You can also try some of your cues whilst they're in pain if you decide that running gait changes might help, because again, you can actually see if it's going to influence their symptoms at the time. Now, another thing to think about if you've got someone with symptoms that aren't easy to recreate clinically is quite often those symptoms are relatively non-irritable. And that's a good thing. That often means these patients are going to be safe to do a return to running program and build up based on those symptoms. Whereas obviously you've got someone that symptoms are very easy to bring on with your test, with everyday life, they're a bit less likely to tolerate running. As ever though, it's going to depend on the patient. So that's the first thought around recreating symptoms. The next thing is, common problem. I think we all struggle for this from time to time. Is you're not really sure what's wrong with the patient. You're not really sure what the diagnosis is. So you feel perhaps a little bit blind going forward in that situation because you don't really know what's perhaps the underlying cause for their pain. Now, in this situation, recreating their symptoms like we've just talked through can be very helpful to guide that diagnosis. But I think too, we also want to try and be as systematic as possible. Think about all the structures that can potentially lead to symptoms. It can be worth kind of writing them down and actually systematically going through. Think about joint, think about nerve, think about ligament, tendon, bone stress injury, muscle injury, etc., and work through what the possibilities are. And then you can try to test them fairly systematically as well to help you work out what the most likely diagnosis is. Now, sometimes this is a process also of narrowing down the options. It can be just as helpful to rule things out as it is to rule things in. So we can narrow those options down, and hopefully, even if we're not able to form a concrete diagnosis, we can have a good idea of what it isn't. So particularly, we want to be able to rule out or at least reduce the likelihood of high-risk stress fractures. So if you have a patient that is getting pain during impact testing, they've got pain on bony palpation, night pain, they're an at-risk category, those people you are certainly going to be more worried about whether they've got a bone stress injury. So you need to test those a little bit more rigorously. Now, the other thing is as well, I think a lot of us can feel somewhat isolated in clinic. If you're not sure with the diagnosis, don't be afraid of seeking a second opinion. It's not an admission of failure. All it is acknowledging that you need a little bit of help to work out what the issue is. And this can sometimes involve getting appropriate investigations done. So have a think about who's in your team that can help you with this. Do you have a good sports physician you can refer to, a good podiatrist you can team up with? Have you got people in your team that you can work together with if you're struggling to find a diagnosis? And if you haven't, get that team around you, because teaming up with them can be really, really valuable, particularly in these complex cases where you're not sure what the diagnosis is. So second point, be systematic about working out the diagnosis, test things thoroughly, try and rule things out as well as rule things in where you can, and if in doubt, get a second opinion. Be prepared to push for investigations, particularly if you suspect something high risk like a stress fracture. You can trust your gut on those occasions. I think we've become a bit reluctant to investigate, but actually sometimes it's an important step in the treatment process, particularly if you're working with an athlete who's got a really big event coming up later in that year, and you and the athlete want to start with a clean slate of knowing what you're working with. You don't want to discover 6 weeks out from that event that actually they've been nursing a stress fracture for some months that you haven't spotted. So sometimes it can be worth getting those tests done earlier on in the process if it's unclear and you think it's going to affect treatment. So final point then with this, if you're not sure what's going on, you struggle to recreate symptoms, hopefully now with what we've talked through, you've got some ideas to recreate those symptoms, to narrow down that working diagnosis. And that's the final point on this, is try and form some kind of working diagnosis, a most likely option. It's not always going to fit the textbook. There's sometimes going to be things that maybe challenge that diagnosis, but I think it's quite fair to say, okay, this seems to be the most likely presentation. This is our working diagnosis, and we're going to go forward with this, and we're going to see how things go and see how you're responding to treatment. So then you can determine the goals, and crucially you can determine what the rehab needs are. So that can guide our treatment. If you're not sure about the next steps, come back to what the patient's goals are and what their rehab needs are. What are their needs in terms of strength, in terms of range of movement, in terms of control or developing power? Even sometimes if the diagnosis isn't clear, we can focus on addressing those rehab needs and gradually progressing someone towards their goals. So that still allows you to proceed. And you know what? Sometimes just having one thing to focus on to start with to see how things improve is absolutely fine. A treatment plan doesn't have to be this huge, comprehensive, massive thing. Sometimes if you're not sure how to proceed, it can be a question of working on one key thing and saying, let's see how we respond to this, and then go from there. Okay, so a few ideas then to help you get unstuck if you're not sure what the issue is, not sure what the diagnosis is, or where to start. be prepared to work with one thing and really make it about achieving that person's goals and hopefully addressing their rehab needs. And please do let me know about any problems that you have treating athletes. Where do you get stuck? Because I'd really like over this series to make it as helpful as to you as possible, to really make it about the clinical issues that you're facing day to day. So don't be shy. Let me know the areas that you struggle with. It can be anything, particular injuries, particular parts of assessment or treatment. Pop them in the comments, and then we can cover them over the next 2 or 3 weeks as we continue this video series. Okay, thanks very much everyone for listening today. I've put a link to our webinar series in with a title there, so do check that out. I can give you inspiration if you're stuck with treating Achilles tendinopathy, lateral hip pain or lower back pain in athletes. We've got webinar series on each of those, and I look forward to your questions and comments. Thanks again for listening. Bye for now.